Hey there, Case 2B here, talking about Vince. It's Brittany, Sam, and Mackenzie again. Okay, so our patient presentation today was a little different than the last couple days. Today our patient was 6 months post-spinal cord injury. And today, instead of being in an acute care setting, we're in a long-term care facility. Today, Vince's chief complaint was shoulder pain bilaterally. He attributes this to he's been using a manual wheelchair for the past 2 weeks because his power chair is broken and is getting repaired, so he believes his shoulder pain is related to that. Functional wise, the patient has been practicing transfers and becoming more independent with his transfers due to being able to use wrist extensions. So he stated that majority of the time he's able to transfer independently, but if the surfaces are not level or if it's a more challenging transfer, then he requires assistance.
Oh, hey there. So, looking at our changes over time, first with the Asia, day one when he was in the ICU, he was a sensory level C6, but motor C5. Day two, he then progressed with just 3 days. Later, he then progressed to sensory and motor at C6. And then day three, it was not performed because this then was 6 months post ICU discharge. Looking at available motions, day one, he was lacking wrist extension, pronation, and supination. Then following day two, which is 3 days, he gained wrist extension, pronation, and supination. And so this is why he was then categorized C6 motor, because he had the motion resisted and against gravity. Then looking at bed mobility, rolling back to chair, and just transfers in general. Day one, he was a mod assist of 2, and then mod to max assist 3. He needed a lot of help. But then day two, so then 3 days later, it was a mod assist of 1. So this was vastly improved. And then day three, so today, Thursday, it was a min assist 1, moderate assist of 1 for transfer of wheelchair to bed. His upright tolerance, so mainly his blood pressure, that vastly improved. Day one, we were only able to get him to 35 degrees of elevation in the head of the bed for about 10 minutes. Day two, so 3 days later, he was able to tolerate this upright position with very minimal change in vitals and symptoms, no complaints of dizziness or lightheadedness. And then when we saw him 6 months later, this was blood pressure, and being upright was no issue at all. So looking at the differential diagnosis over time, there was really nothing significant, no big changes besides what he's gained in motion. And the biggest change we did see, which was mentioned in the slide before, was his frequent orthostatic hypotension bouts. This was vastly improved, even 3 days and 48 hours being extubated. So this was really the only thing that changed across the times that we saw Vince.
Oh, hey. What could have gone differently or better? Well, we decided that we could have been a lot more confident in the plan that we made before we went into the room, and just general confidence in our skills. And then transfers could have gone a little bit better, especially with confidence and just setup. But we made it through, and you just kind of have to trial and error and see what works. So the third day went a lot better with that. And then we think that we could have done a little bit more thorough subjective and just kind of getting to know the patient a little bit better. But that first day had some communication barriers with the patient being on a ventilator, and we didn't know how much English he spoke. But besides all of that, I think that we did things that we did very well were check vitals constantly throughout the session just to make sure that he was responding to increase in activity very well, and we had no issues. And then we also did a very good job building rapport and using patient-friendly language throughout every session. I think our group did a very good job doing that. So, yeah, happy Thursday.